about their service. Outpatient, they can choose where they go. Inpatient is not necessarily that same level of member impact. We were showing outpatient, professional, and pharmacy as well, and you can see that all of the utilization of those categories has dropped as member cost sharing has increased. On the right there, we're still showing a pretty significant difference from the region's norm. So what this is reflecting is that, again, for inpatient, for example, TriMet's utilization is still higher than the book of business. Now, if we jump to the top table, the cost of claims are impacted by two things. One is utilization, and one is the cost of services charged by hospitals, providers, etc. So the top table is taking into account both utilization and cost changes. And you can see that we've seen a pretty significant drop in medical and pharmacy cost for your union membership, but it is still pretty significantly higher than the region's book of business. Another potential impact of cost is retiree coverage. And the state of Oregon requires that pre-65 retirees be offered coverage if you're a public employer. The difference for TriMet is that there's no requirement in that law that TriMet pay the cost of that coverage. And currently TriMet does pay the cost of retiree coverage. Most Oregon employers that we work with do make it available, but they generally do not subsidize the entire cost of that. So depending on, sorry.
I think I have a question here.
Clarification, so you're talking a supplemental for Medicare?
No, this is pre-65.
Okay. I'm 64 today, so I'll give something more fun.
You're looking at both of them. So although there is some collective bargaining agreements with public employers that have 50% subsidy, 25% subsidy, it's rare to have 100% subsidy of that retiree coverage. Coverage for retirees also is generally limited to the retirees and their dependents at the time of retirement. So if I happen to be single when I retire and I get married, that spouse would not be eligible to be on the plan. It would just be the dependents at the time of retirement. There is a provision in the law for coverage for surviving spouses in Oregon, which essentially says that spouses who are over 55, when the employee, for example at TriMet, would pass, they can be offered, but they must be offered coverage to age 65. But again, TriMet would not have to pay for that coverage. Now if we move to post-65 retirees Medicare, there is no requirement for public employers in Oregon to provide coverage or offer coverage for those retirees. Most public employers do terminate employer-provided or offered coverage at age 65. There are some exceptions, a couple that I'm aware of, Multnomah County and Clackamas County. But if they do continue post-65, they are paying the entire cost of the coverage. So I wanted to touch briefly on how to impact premiums. There's the obvious one, which is to change your benefit plans, but that's difficult, and it's not as straightforward as saying we're going to change our benefit plans. So a few other things that can be done is to change utilization patterns. Having employees make better choices for where they get their care. Emergency room versus an urgent care versus a doctor's office. Significant cost differences between those facilities. Using brand name versus generic drugs, also very significant cost differentials with that. You can impact the health of the population, encourage healthier lifestyles, no tobacco use, more physical activity, healthier populations result in lower costs. We are seeing a lot of employers really focus on wellness programs for their population. And then I think we can't overlook that chronic conditions happen. They're in every population across our country. So when a condition is identified, how do we better manage that? How do we make sure that diabetics or heart patients are taking their drugs when they need to manage their condition and control their cost? There's another way to impact premiums, which is competitive bidding of the insurance coverages. Some of the potential advantages there obviously are keeping their pencils sharp on how much they're going to charge you for administrative fees, how they manage your chronic conditions. But one of the biggest drivers of, or the biggest driver of your plan is actual claims. So if it's Regents or it's MODA, Cigna, Aetna, any others, your claims are still your claims, and that's about 90% of the cost. So to the extent that they manage the claims better, that certainly helps you. But the administrative fees are kind of in the margin from a cost standpoint. And one other thing that can't be overlooked when you're competitive bidding is the impact on your employees. So for example, provider disruption is key. You want to make sure that you don't have 100% of your employees lose their doctor and have to find someone new. So looking at disruption of providers is obviously important. There is the potential for a one-year impact. So I want more membership as an insurance company. I'm going to come in, offer you very low competitive rates, and then next year we're going to jack your premiums to compensate for that. So it's something to be cautious of. And then we can't lose sight of that not all the plans are the same behind the scenes. Some have more progressive profit sharing with the providers, meaning if the providers are doing the right kind of care, they get paid more. If they're not doing cost-effective care, their reimbursement rates are lower. So something that needs to be considered when bidding as well.
Wow. So Mitch, we have a couple questions here.
Well, thank you. That was quite a comprehensive report. The summary was really nice because it ultimately begins to answer some questions that one might have. But I still have a few questions. And I'll start off by saying that ultimately, healthcare is something, healthcare coverage is something that's very personal. And I think some of the things you highlighted here in the final slide really highlight that. And as an organization, many of the folks that we're talking about here are frontline employees and team members that really are the face of who we are. And across the nation, we've got data and information that tells us that transit workers are high utilizers of healthcare and could have some healthier lifestyles. And it's not something that's unique to just our organization, but many transit organizations across the country. One of the specific questions that I have really relates to the age. The average employee age and its impact on cost. On page number 5, it talks about the average age for both represented and non-represented employees and team members here at TriMed, and it's a significant age. How do I say this? We have a wiser population that we work with. And so, is there any data that actually tells us? I know there's a direct correlation between age and utilization. As we age, there's almost a hockey stick kind of effect. Once we hit about 63 years old, the utilization goes up significantly. And so as we look at this, how do we separate out kind of the impact of the age-related utilization and cost and the overall cost of just the design of our health plan?
I might actually even ask that healthcare actuary to address that, because I think it's an actuarial question more than a benefit design question. Mm-hmm. The providers, and we have a tool as well that would look at the demographic risk based on age and gender compared to an N of 1. Mm-hmm. I didn't bring that with me today, but we could certainly come back to you with, based on this age difference, what is 6 years compared to the Regions book of business? How much is that worth? And again, the healthcare actuary probably has some data.
On a real broad basis, essentially, an added year of age adds between 2 to 3% to cost. Mm-hmm. So 6 years is, in the 12 to 15, 16% range, strictly just due to age, all else being equal.
So, and as a board and administration, as we look at all this information, there's a direct impact because of the age difference that we're seeing compared to the Regions benchmark. And as we talk about the Regions benchmark, what does that look like? When we say Regions benchmark, is that the Regions' entire book of business and how they've been? Because that's a critical component that we're utilizing as a comparison in this, in this data and in this look at the information. Can we get just a brief description of what the Regions benchmark looks like?
So it's their commercial book of business, so it's not Medicare. And it would be all of the groups that they provide insurance coverage for, whether it's on a self-funded basis or insured. So it's private and public employers. It's across industries, it's across plan designs, and it's also across contributions from a payroll perspective. So it's a pretty broad benchmark. Regions can provide different cuts of data. So if you want to look at plans that are just public sector or plans that are only this plan design, we could certainly get different cuts of data. What we started with was the broadest benchmark available from them.
Can I follow up on that? Do different insurance companies have different member characteristics. So in other words, does Regents go for a population that is different than a Kaiser or whoever? I don't know who all the insurance companies are. Or do they all tend to be fairly similar?
I would say in Oregon, those two employers kind of go after almost all employers. From an employee perspective, the question that healthcare is personal, or the comment that it's personal, what drives someone to Regents versus Kaiser as they choose a health plan can vary greatly. As typically, HMOs have had families where they want a low copayment because they've got several children, they go to the doctor a lot. I don't know that that's completely the case anymore, as Kaiser is starting to introduce deductible plans that look less like an HMO, even though it's still a closed network of providers. So I would say that in Oregon, Regents and Kaiser are going after the same set of providers, especially in Portland. So if you had members across the state of Oregon, Kaiser's not an option there. Regents would be able to offer a network there, but Kaiser wouldn't. So for TriMet's population, that's really Portland-centric, both of them would be competitive in going after the business.
I would just, you stated that we could look at a different benchmark, and I would encourage, some type of benchmark that allows us to see some comparable data to our workforce population. And you mentioned just public employee organizations or plans. This is just me speaking, and other board members can pipe in where they see fit. But I know I would be benefited to actually see a little different benchmark in comparison to what we're looking at here, because I think it would give us a better idea of what we're working with. One more quick question before I be quiet. The actuarial value calculator, that to me is interesting because it begins to kind of normalize the way it's calculated. I'm assuming because ultimately we can always. You come to the table with estimations, and you can have two folks come up with different types of values, but can we get just a little bit of an explanation of how this new, I'm assuming it's new because it's attached to the Affordable Care Act, how this actuarial value calculator works?
We're a bit frustrated with it, quite frankly, because the number of inputs into it are not as robust. So it's, 5, 6, 7 inputs. Whereas our proprietary, and I'm sure other actuarial firms have much more detail about how you feed in. The way to normalize this is something that's nationally recognized, however. So we use the actuarial value calculator. The purpose of this calculator was to determine the platinum, gold, silver, and bronze plans for the marketplaces. So it's a normative calculator. We would probably come up with slightly different actuarial values. Chiron would probably come up with actuarial differences, but they should be within a few percentage points of each other.
And just one final question to that. The data points that go into the actuarial value calculator, are they based on actuals? Are they based on assumptions, projections? I mean, the data that goes into it to actually put this information out.
They're plan design features, so
Okay.
it would be deductible, co-insurance, out-of-pocket maximums, pharmacy co-payments. It doesn't look at TriMet's population versus the other populations that we've compared against. It's really just the value of that plan design. So if you took $1 million and put it through the plan design that TriMet has versus the plan design that San Francisco has, what would that difference be? Ignoring all other factors.
Excellent. Thank you very, very much.
Yeah. There's a couple businesses have started up, and one of which is Zoom Care. And is that going to have an effect, not just on any plan, or is that getting legs? And if you can talk to that, or briefly, yes, no, to drive down the cost, make it more accessible to the public.
Organizations like Zoom Care are becoming more popular, and insurance companies nationally are starting to contract with them as a preferred provider. The great thing about them is they can provide some of that initial care. I need an antibiotic for my child's earache, whatever that might be.
Yeah.
And they are generally less costly than many of the other service areas.
And in your crystal ball, both of you, What do you think the effect of the ACA is going to be in 3-4 years? I won't quote you.
Well,
Hopefully, it's going to be going to push things down.
I hope that it does. What
Yeah.
I think we've seen at Mercer is that the cost of insurance trend increase has actually stabilized and dropped some over the last several years.
Yeah.
We'd love to be able to tell you exactly why that is. We think that the Affordable Care Act is having an influence on providers, potentially their cost, what members are thinking about insurance. I don't know what the result will be. I'm hoping that with some of the effective research that's going on about what types of care are most effective for outcomes, it will have some influence. If we have less people going to the emergency room and the hospitals transferring that cost onto commercial carriers such as TriMet, that will have some influence. But we're probably a few years out before knowing that.
I mean, you don't have enough information to, I mean, not just you, but all people like Mercer. Okay. Thank you.
Director Bethel?
Thank you. I have a couple of questions just to try to get an idea about some impacts. One on page 6 where you talk about occupations where transit workers are not defined as high-risk professions within the ACA. What impact will this have on the cost of insurance? I think, Aaron, you said that many of the injuries that we have were about 90% soft tissue. And if the claims for that continue to be in rise, what dollar impact is that when we talk about insurance? Even though they're not high risk, will an insurance company begin to look back and say, here's a risk factor, so therefore we need more dollars in premiums?
To the extent the injuries are happening while at work, they would be a workers' comp claim versus an insurance premium claim. So to the extent that they're being incurred at work, we will have virtually no impact here. I would say there's other things about a job, you know, for example, I sit at my desk all day, that has an impact on my health. It's not going to be a workers' comp claim. So I do think that there's some things that play off of each other, but soft tissue that happens at work would not be an impact here.
Okay. Final at this point, that 40% excise tax, which I can't really wrap my head around at this point. But again, talking about impacts, what is going to be cost-wise for TriMet in terms of providing insurance. Who has the responsibility of paying that 40% excise tax on the Cadillac Gold, Bronze plans, however you want to name those things that exceed those thresholds? And is there any participatory type things that could possibly happen to offset that? For instance, if the plan for TriMet is a $20,000 thing, you know, for a single person, 40% over the 10,000 too. Now, who pays that? And is it a fair assumption that part of that either comes in two ways, either the cost of insurance has to be reduced, or do we talk about the possibility of a share in terms of paying excise tax? And I'm just throwing out some questions because 40%, if that has to be paid or absorbed by any corporation, and but not specifically for TriMet, it does add a cost to the budget.
Can I just ask one clarified question before you answer? Is the 40% just above the, so if it came in, we're talking hypotheticals because we don't know what our data is going to be at that point in time, but it's whatever's above the federal threshold. So it's not, it wouldn't be the total cost, because that would be enormous.
Yes.
And it still would be big, would just, but
Right,
it would just be above.
So if, for example, the cost was $11,000, it would be 40% of that $800 differential for a single. The way the law is written is that if you're insured, the insurance company has to pay that excise tax. I will tell you, I don't know any insurance companies that will not be passing that on to employers in premium. And then I can't speak to how TriMet might share that cost.
So what you're, just clarifying what I'm hearing. The insurer, the employer, is responsible for paying the excise tax.
The insurer in this case is Regents or Kaiser.
Okay, all right. So the insurer, whoever, is responsible for paying the excise tax.
Correct.
And we do know, beyond a shadow of a doubt, they will pass the cost on to those, you know, who have those types of plans.
Correct.
And so then that then comes down to an employer situation, where that employer, i.e. TriMet, will have to face increased premiums and a way of reducing those costs or paying those costs. And I know you can't address as to how we do it, but am I clear enough in my thinking there?
Yes.
Okay, thank you.
Brandon, did you want to add any to that?
No.
He's smiling too much.
Actually, on that last point, thank you for asking the question, because that's something I didn't really realize. And to David, I think as we look at the financial forecast, you know, we've really got to look at that assumption in terms of what we expect future health insurance rates to be, given this excise tax. Yeah, it was a piece I was never aware of or didn't fully understand.
It is factored in.
It is factored in?
Mr. Board President, we do have 2 additional presentations, so.
I need to ask this.
You can see there's a lot of interest, however.
Yes.
Aggressive wellness programs. Do you have any stats on how that affects overall costs of healthcare?
It's the question that every employer asks, and I get to tell you every time, we don't have great data. We think it might impact between 1% and 2% of cost, but we don't know long-term yet, because wellness is if you get people in the 20s and 30s to do the right thing, when they hit 50, that's when you're going to start seeing the results of healthier employees. So wellness is generally not a 1 or 2 year impact. If you buy a metric test, you get everyone exercising this year, you aren't going to see a 10% drop in your claims next year. It's hard to measure something that you're avoiding in cost as well.
We've had it for 25 years in our health plan, so I'm just curious. It's been effective. That plus workplace ergonomics. Anyway, I digress.
That's good. Did you have something?
Yeah, I might ask Carrie just to talk about defined contribution plans as a way to manage the potential excise tax risk.
So there is a lot of buzz with employers now to have a defined contribution approach that is similar to what happened with pension plans over the last 20 years. In that, employers are now saying, we're going to just tell you how much we're willing to pay for the cost of coverage, and employees have to pay the differential. We're seeing a big move to that, or at least a lot of discussion around it. The challenge with defined contribution and the taxation, or the excise tax, is that the excise tax is looking at the total cost of care of the plan. It's not looking at how much the employer pays versus the employee. So one of the considerations around defined contribution is that perhaps an employer would pay the defined contribution up to an amount that would avoid the excise tax. And if the employee wants to buy something that's richer than that, they're not only responsible for their cost of that coverage, but for the excise tax. So that is at least a discussion point that some employers are having.
This is a nightmare.
Yeah, and I have just a couple clarifications. I want to make sure I've got this and see if it's right. First off, the 90-10 plan that's been in effect since September 12, that's still up in the air in terms of the final decision, or is that?
It is in effect, and it's been appealed to the Court of Appeals by the ATU.
All right. So those savings or reductions, we don't know whether that's going to continue. So that's an issue we got to deal with. And then the other one, I noticed that under contributions to say that TriMet does not have any contributions for its full-time union plans at this time. I want to make sure I understand, because I think as a result of status quo, since we're operating without a contract, aren't the union employees actually paying a portion of their healthcare costs right now?
Yeah, under the contract, the plan design is that the employees contribute 0%. Once the contract expires, there's a provision in the statute that allows the employer to pass on to the employees the year-over-year cost increase. So they're not sharing a portion of the premium, they're paying the actual increase in cost from one year to the next. Now, in this case, we're 2 years past, So we've got two contractors, so we went up, and then the Regions plan at least went down. So the net difference is what they're paying on a temporary basis until a contract is settled or implemented.
I just want to make clear what, from their perspective, they're paying right now, I think is what's going on, but it is as a result of the financial contract. Okay, good. I think we do need to move on. Let's move on then to, I guess, the next, which is the other post-employment benefits discussion.
I'm going to go through this quickly, in case you have questions again. That's just to talk about OPEB in general, and give a brief definition of really what's that mean. What do you have to disclose today? How do you actually go about determining this liability? What are the factors that we have to take into account? And then just give you a brief overview of what some other employers are actually doing from a strategic point of view to try to manage this liability. And again, OPEB is, as we all know, is other post-employment benefits. And it's basically any non-pension benefit that's provided once the employee leaves active service. And the typical examples are medical, drugs, dental, vision, life insurance, depending on what the employer happens to offer his or her employees. Now, prior to GASB 43 or 45 going into effect a few years ago, typically the only thing that anybody ever saw was what is called the pay-as-you-go or the annual cash cost of the benefits. That's it. Nobody really knew anything else about it. GASB basically said, hey, people are actually earning the right to these benefits over their working lifetime. So it's really it's really a compensation issue, and it needs to be treated from a disclosure point of view similar to pension benefits. You need to recognize the cost. And so you really have to recognize the cost over the service period of the active employees as they're actually earning the right to these benefits. And again, it started off, at least on the low end, it's like you don't have to fund it, there's no requirement to fund it. And you just basically need to provide some information so that somebody reading the financial statements can understand the commitment that's been made. So they want information on what's called the actual accrued liability. So what's the value of the promised benefits that people have earned to date? Is it funded? If so, how much is it that's been funded? And then again, provide what they call additional information that can be useful to assess how's this going to impact future cash flow demands on the employer over time. And most of this information is basically buried in the notes of the financial statement, so you have to dig through the notes to find it. But they want to know the annual required contribution, which is how much money would you actually have to put into a fund, into a trust like you do the pension plan, so that over a period of time, and then the situation amortizing the unfunded over not more than 30 years, if you put this money away, you'd actually have this, and all your other assumptions were perfectly met, you'd have enough money sitting in this account to pay all the future benefits. They also are showing what's called the net OPEB obligation, which is really the difference between how much you actually are contributing, which say is just your pay-go cost, and what this ARC is. And so your pay-go is well less than this ARC. So over the time since it's been implemented, you've got this financial items growing, and again, over time, it tends to start to approach that accrued liability. You show that liability, the assets, the unfunded. What that unfunded is a percentage of your payroll to give somebody an idea of how big the number is. And then you provide information that really describes what the benefit is, how people earn it, what's it look like, and then what your funding policy is, which again for you currently is just pay as you go. Now when we determine it, essentially what we're doing is, it's called the present value of future benefit payments for all your current retirees and your current actives. This never takes into account people that you may hire in the future, so it's, you do evaluation as of 6/30/2013 is who are your existing retirees, who are your existing active members. You're basically doing projected cash flows. You're saying for my existing retirees, here's how I expect for each one of those people to pay their benefits in the future. For an active person is, okay, when do I think they're going to retire, and then what their benefits are, and then you're discounting them from the time value of money back to the current point of time. We do need to take into account, again, initially the demographics, how old they are, their age, their sex, are they government dependents. And then you're getting into, for the active employees, well, how many of them are going to actually leave service, either before they actually reach eligibility for the benefit, or maybe they what we call deferred vested. They've earned the right to the benefit, but they're still maybe 10 or 15 years away from retirement when they left, so they're going to come back in the future and get it. What's the probability they actually become deceased before they even get the benefit? What's the probability of actually going on disability? What's the probability of once an active person reaches retirement age, when will they retire? Not everybody retires, so the first opportunity to retire. What's the current cost of the benefit? Then how much do we think that's going to go increase in the future for healthcare? Realizing we could start with somebody you just hired at 20, the actuarial table is about 120, so I have to predict what I think healthcare is going to be 100 years from now. It's a good guess for any of us. And then what do you use for a discount rate? And for GASB purposes, they're very specific about what you use, and that if you're going as a pay-go basis, the discount rate has to be consistent with what the employer's return is on their general assets. Because that's really, in their mind, the source of the funding for that benefit in the future. You actually have a trust set up, you can use the expected return on your trust assets, similar to what you do to a pension plan. And if you're somewhere in between, there's an interpolation process that you use right between the two numbers. And then there are other assumptions that get play, like increase in payroll, inflation. Are you, not to get too in the weeds, but is it a plan where you have an implicit versus explicit subsidies and all kinds of other fun things that come into play when you're actually doing these numbers. And so what usually happens is the actuaries would sit down and by looking at your plan, looking at what's happening, they come up with, here's what we believe the appropriate set of assumptions to use for this valuation are. And they sit down with the employer and say, here's what we think, here's why we think these are the right numbers to use. Then they sit down, as well as any of their other advisors if necessary, and either they accept the recommendations, or they may say, no, I don't want to use this assumption, I want to use this other particular assumption. Then as the actuary, we have a determination to make, because we're governed by what's called the actuarial standards of practice, which are a series of rules that are put in place that dictate how we practice. And some of these assumptions do have reasonable ranges, and why my recommendation might be you ought to be this. You say, well, no, I'm more comfortable using this assumption as long as it's within a reasonable range. I'm okay. We use those assumptions. To the extent I don't think it is, I have two choices. Either I can say, you know what, this is so unreasonable, I'm not even willing to do it. You need to find somebody else. The other thing I can do is say, okay, the employer mandated that I use this assumption, but in my professional opinion, I don't think this is reasonable. And if you use what I think is a reasonable assumption, here's what the number would be, which again is a report that typically an employer doesn't want to have because that generates all kinds of other issues. The accountant's going to raise all kinds of issues. And so, usually that doesn't happen. And in my entire career, I've never had an employer try to mandate an assumption that's unreasonable. But it can happen. And so just in case somebody came back and said, you know what, I want to use a 10% discount rate so I get the liability really low, I don't think you're going to find an actuary that's going to let you do that. Your accountant's probably not going to let you do it either. And so one of the things we were asked to do is to just, at a high level, look at the current assumptions that are being used for your most recent OPEB evaluation, and again, high-level review, reasonableness of what we see out there in the industry. The assumptions are all reasonable. They're consistent with what you would typically see out there in the marketplace. We've also were hired to actually kind of develop a background opinion level just on how one sets trend rates and discount rates and the interrelationships between it. And as a result of that review, we have some things we just would consider that TriMet, its current actuary and its investment advisor, because these all tie together, consider some changes in the assumptions that they could be considering today already. And it really has to do with the interrelationships between discount rates and trends because of the current economic environment and some of the emerging belief that it's going to be a number of years before things significantly improve. And so that would be, is the current discount rate of 4.5% still appropriate? We're actually seeing from some of our clients, the average rate now for the purely pay-as-you-go plans is between 3.5% and 4%. And if that's the only change you made, that would have a pretty significant increase in the liability. But the ultimate trend rate is related to that because again, the long-term view on ultimate trend is it ought to be related to what we think the long-term rate of growth of GDP is. And some of the really long-term discount rates for kind of the assets you would use for your kind of general fund purposes, which are really low risk, are around GDP returns as well. So to the extent you really lower the discount rate, that ultimate trend rate should really fall as well. So therefore, that 5% would fall down as well. And that would tend to offset the increase in the discount rate. So those two would tend to balance each other out, all else being equal. The other assumption that we would actually recommend you take a hard look at is the grading period, which is essentially what happens is the trend for the initial period is what you're really seeing is your increase in medical costs. You have your ultimate, how long does it take to get there. Your current valuation uses a 7-year grading period, which we feel is actually really low. Typically, what we're seeing in the market is between 10 and 15 years. And so it's going to take longer to get there. That, unfortunately, does have an increase in your liability. But we do believe that's probably more consistent with what we're seeing as an industry practice. But the 7 years isn't something that you say, oh no, this is completely wrong. It's within the range of reasonability. It's just we're seeing the more average, middle of the road, really extending that period out. So unfortunately, we have these liabilities, so what do you do with them? And kind of the first thing when you're really looking at managing liabilities, you have to look at legal restrictions, because different states have different rules about what you really can do. So, what changes can you make for existing active employees? What can you do for people that are in that vested term status where they've earned eligibility under the rules of the plan, they've left employment, they don't reach retirement eligibility? And what can you do with the existing retirees who are actually receiving benefits? And there are different rules in different jurisdictions about what it is you can and can't do. And then you also always have your collective bargaining considerations that overlies everything that you do. But typically what we've seen is kind of the best case when we're looking at the strategy is, since this liability is really looking at the present value of long-term cash flows, and what are those long-term cash flows associated with this benefit, and what can this, from a long-term financial projection, what can you afford to pay for? And where is the disconnect between there, if there is a disconnect? Then you also want to look at, well, what's my liability relative to similar employees in the transportation industry at my level of, employment, and what is their funding strategy? Because when you're looking at how the particular bonding agencies are going to look at you, that's part of what they look at. If everybody else is fully funding their plan and you're not, that's not a good thing. If nobody's funding it, you're in the same boat as everybody else is. And so it's kind of bringing those pieces together to really decide what is it that you want to do. And what we've seen, if I kind of break it up, is one of the things we've seen other employers consider is eligibility changes. What do you do? Some of changes, which is in some ways the easier one to do because it doesn't impact anybody that's working today, is, okay, future new hires, sorry, we're just not going to give you this benefit. Under the theory that at least you have a working career to try to figure out how you're going to pay for this benefit. We've seen some that starts to explore actually making, to the extent they're allowed to, making changes in current practice. And some that, and it gets into what do you do for somebody who's close to retirement versus somebody that you just hired last week. And what you want to do about making changes around benefits for the current actors. We haven't seen a lot of movement for existing retirees. A lot of people don't want to deal with that because you made them a promise, they relied on that promise, they retired hoping they would get that promise. It doesn't seem really fair to pull the rug out from them from that point. You see that on the corporate side occasionally, but I rarely see it on the governmental side. And then you can also look at kind of playing in the middle, saying, well, I don't want to take things away, but maybe I start to increase the requirements to actually get access to the benefits, to say instead of you having to work 10 years, you have to work 20 years or 25 years, and kind of deal with it that way. You can also look at the whole thing, benefit changes. You can reduce the level of coverage you're providing. You can reduce the amount of money that you're actually contributing towards the coverage. You can start to limit the plan options to maybe a different set of options. You can even maybe look at providing a different set of options to retirees versus actives under the theory that they definitely have different needs. And so maybe it makes sense to have some different level of benefit coverages. The other thing we've seen some move to is a defined contribution plan. Because if you can put in a defined contribution plan that you can support the cash flow pieces of it, and it meets the definition of a defined contribution plan under GASB, the liability from what shows up in your balance sheet goes away. And So we've actually seen employers start to look at it, actually have some clients that actually implemented them. And the decisions they go through in it is, you make it voluntary, where you say, here's this option, if you want it, great, if you don't, you can still keep your existing plan, or you just say, no, this is the new plan that you're moving into. Do you do that just for actives, or do you even give current retirees the ability, if they want to say, hey, here's this option, do you want to join it? And one of the things that's starting to make this a little bit more palatable for people to look at is through the exchanges that hopefully will be successful. But again, just on the face of it, if you went out today as a pre-Medicare retiree at 60 and tried to get your own individual insurance, unless you are really, 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 really healthy, good luck. And if you can find it, it's extremely expensive. The plans now, because of the rating restrictions, those plans actually are a lot more affordable. So therefore, there are more options. And arguably, particularly, we've seen with some governmental employers, because their existing plans really don't address the retiree who may want to move someplace else. This may actually be a good option so that they have available, but for some reason I want to retire in Florida, or I want to retire in Arizona. I've got something that I can use. And I kind of want to close with a real life example of the process that I was involved with a governmental employer that had an annual pay-go cost of about $50 million a year. As part of this analysis, they also determined that they actually could afford to divert an additional $20 million to help pre-fund the benefit going forward in the future. And their long-term commitment was that we could probably afford to increase that $70 million by 3% a year in the future. So it's kind of, that's what we can afford to do to provide this benefit. So I wanted to develop a redesigned plan that really had three goals. One is, whatever that long-term financial commitment was, it needed to be within that 70 million plus 3% a year in the future. Secondly, they wanted to reduce the overall liability in that annual required contribution amount by at least 30%. And they also wanted to either reduce or eliminate the liability associated with future hires. And what they ended up with is about a year process, a lot of negotiations, a lot of backroom arm twisting, that their final plan design was future new hires had no coverage. And they basically were banking on a lot of time that hopefully the Affordable Care Act was going to be successful on a long-term basis so that they could plan for and know what it is they have to fund. They also left the existing retirees alone. Again, in theory, that's been promised. We don't want to mess with that, and we're just going to leave that alone. Then they split their existing active employees into two groups. They said anybody that wasn't within 5 years of retirement eligibility, we're going to put you in a defined contribution plan. Everybody else that's currently active, we'll give you a choice. You can join that defined contribution plan if you want, or we're going to have a plan that's like the current plan, but we're going to basically, instead of having the employer contribution, which their plan was they paid 100% of a particular benchmark plan, and then if you wanted a plan that was more expensive than that, you paid the cost difference. They said that benchmark amount in the future will only go up by 3% a year, or the actual, basically CPI, or the actual rate of increase of the premiums, whichever's lower. Pick which one of those you want. And they defined their defined contribution plan. What they did is we did an analysis of saying, what is the value of that reduced defined benefit plan over a person's working lifetime? And you discounted that back at a 5% discount rate, because again, not saying we expect you to earn it, they expect the employees to earn 8 or 9% in these accounts, but more about accounting. When you retire, we'll throw that money in an account. You use it how you see fit. If you want to buy a really expensive plan and spend it down in 5 years, that's up to you. If you want to stretch it out and all assumptions are met, it'll actually be enough to cover you over your working lifetime. And at the end of the day, we were able to design something that did fit within their cash flow requirements and actually produced a 50% reduction. And that's primarily because they actually got a very big enrollment from those people that were within 5 years or currently retirement eligible. They actually decided they'd rather have the defined contribution plan. because it's kind of a known entity, I got that cash sitting in an account. And I'd rather have that there than some future promise that you come back 5 years from now and say, oops, I want to change my promise again.
Questions? Questions? There you go.
I know you're surprised. Really speechless, I'm sure. So, as we take a look back at I want to take a look at the discount rate and talk about that just for a moment.
Which page is that, sir?
That's page 7. So, I mean, when we start to talk about, taking a look at this OPEB liability, I mean, it's all about the assumptions. And that's really where a lot of this lies, because we're assuming something that we're projecting out into the future. The discount rate of 4.5%. You know, we hear discount rate, that could mean a plethora of things, but it really takes a future number and then discounts back to our current net present value, so to speak, or present value of that data. What is it that we're utilizing to take the number forward? And is that number different? So is it inflation? Is it inflation of the underlying healthcare cost that we take forward and then bring back by utilizing a discount rate of 4.5%?
Yeah, it's the actual expected future cost of healthcare, and which is healthcare inflation plus improvements in technology and government regulations. There's a whole bunch of components that go into that, and so you kind of that's focused on the current is what are your current costs, and then on a long-term basis, your kind of long-term economic assessment that's common in the actuarial community is, you know, if healthcare, to provide a little bit of context, back before anybody actually even started measuring OPEBs on the corporate side back in the late 80s, healthcare was somewhere in the 11 to 12% of GDP range. And at that point, we were all saying, geez, we're already at 15%, the world's going to fall. We're at over 18% now.
Yeah.
And so, but the point being, there is some limit. It can't be 100%. And then kind of prevailing opinion now is it's probably really about the 25 to 26% of GDP range can be supported. And after that, they think the long-term increase in healthcare is going to be more than inflation because there's some productivity components, but they think long-term is going to be close to what long-term GDP growth is. So that's really what you tend to peg. And right now, the kind of common consensus for long-term GDP is somewhere in the 4 to 4.5% range, if you ask anybody. So that's kind of saying, all else being equal, that's where your long-term trend rate ought to be somewhere in that range. But if you're, again, to take the other side of it, because all your economic assumptions have to fit in together, you know, a 4.5% discount rate, if you were using a long-term inflation assumption of 3%, would be implying a real rate of return of 1.5% for very conservative assets, which is probably a little aggressive these days in time. So if you're at a 3%, you know, inflation and a 4 to 4.5% GDP growth, then maybe your real rate of return ought to be more around the 1% range, which means your discount rate ought to be 4% rather than 4.5%. So the kind of discount rate goes down, but then the trend needs to go down with it to keep all of those economic assumptions consistent with each other.
I'm going to get highly technical with my next question or comment, but ultimately you say the 1 to 1.5% real rate of return. I mean, that's, and you say for a highly conservative asset, right? And so that's in conjunction with, let's say that you know, our next presentation could be the pension plan. The pension plan would have a higher rate of return, a real rate of return, because ultimately the assets are not as conservative as we would have in the OPEB liability situation. Correct. Okay. I was just looking for that clarification.
But the other extent, to the extent you actually started to fund the OPEB liability, if you fund it like you do the pension,
correct,
then you could actually use discount rates that are more consistent with what you would use in the pension plan, because you've got assets that are actually being